Aloha, everybody. I'm Marjorie Mao, and I've been asked to give a presentation on diabetes. And the title of my presentation is What Every Legacy Person Should Know About Diabetes Prevention and Care. So diabetes mellitus, or diabetes, is an old disease. This is a Ebers papyrus from 1500 BC that is thought to be the first description, medical description of diabetes, in which diabetes treatment was reported to be drink a mixture of elderberry, acid, plant fibers, milk, beer swill, cucumber flowers, and green dates. Since that time, thankfully, scientific breakthroughs have happened in diabetes. Historically, diabetes was a fatal disease, and you were treated with fasting if you developed especially type 1 diabetes. And in 1921, in Toronto, Canada, the discovery of iletin, later known as insulin, was discovered. And in 1921, a longevity experiment was conducted on the first living organism. Marjorie was the name of the dog here. And it was successful, enough so such that in January, just 2 months later, a pharmacist purified an extract, which was called Collops extract, injected it into the first human being, who was 14-year-old Leonard Thompson, pictured here. And in 1923, this scientific team was awarded the Nobel Prize in Medicine to Banting, who was the surgeon, and MacLeod, who was the administrator. And because the students were not named that were critical to the experiment, they then later shared their Nobel Prize with Best, who was a graduate student, and Collop, who was the pharmacist that helped to discover insulin. And in 1923, insulin was available as a bovine and porcine formulation in the United States. So what is diabetes? Diabetes is recognized and diagnosed by the presence of excess glucose in the blood. The clinical diagnosis depends on the measurement of glucose levels, and there's 3 different ways of diagnosing it, either by hemoglobin A1C here, fasting plasma glucose, or through an oral glucose tolerance test. So virtually in practice, we use hemoglobin A1C and sometimes fasting plasma glucose. Here are the cut points. So normal is less than 5.7%, less than 100, fasting, and less than 140 on a 2-hour oral glucose tolerance test. Each of these ways needs to be repeated to have on a second day for a diagnosis to be established. Diabetes is classified as type 1, which is due to an autoimmune beta cell destruction leading to absolute insulin deficiency, and type 2 is due to progressive loss of beta cell insulin secretion, usually within the context of insulin resistance. And gestational diabetes is diabetes first recognized during pregnancy and usually goes away after delivery. 5% of diabetes cases generally are type 1, 95% to type 2, and gestational diabetes occurs in about 5 to 10% of all pregnancies. So what causes diabetes? From the initial studies done in the 1920s, you would think that the pancreas was the culprit, but it turns out that type 2 diabetes is caused by multiple organ systems contributing to hyperglycemia, which is the way that we diagnose diabetes in clinical practice. We now know that the primary defect in type 2 diabetes, the most common form, is beta cell defect. Beta cell is the cell in the pancreas pictured here and here that produces insulin in the body normally. And then there's a cascade of metabolic changes when you have a beta cell defect that has contributions from fat, the kidney, muscle, the brain, the liver, and the gastrointestinal system, the gut. And they all contribute to cause hyperglycemia, the hallmark of diabetes. Hyperglycemia then leads to prediabetes and eventually leads to diabetes. Not eventually, actually, we'll talk about that in a bit. There are many medicines that have been developed over the years to treat diabetes. This is just a time frame from 1923 to 1956. By the way, the Egyptian concoction doesn't work. So it's not on this chart, but 1923 insulin does work. 1956, we really only had two medications to treat type 2 diabetes. And then in 1983, human insulin and a second generation of sulfonylureas. 1990s, there were a plethora of different classes of medications. In the 2000s, there were additional classes of medications. And today in 2021, there are 3 different sulfonylurea brands. There are 7 GLP-1 receptor 1 agonists. There are 4 DPP-4 inhibitors. There are 4, and these are all classes, SGLT2 inhibitors. There's still only one biguanide in the United States, it's metformin. And there are 5 human insulin analogs that are in clinical practice today. So in summary, there are multiple anti-diabetic medications. Most of them are oral medications taken by mouth, and 2 are injectables that are not insulin, and 5 insulin analogs. You may be asking, what is the best treatment for my diabetes given the number of choices a practitioner may have? This is the most recent algorithm for treating type 2 diabetes. The first line therapy is metformin plus a lifestyle program, and we'll talk about that more in just a minute. And then the algorithm gets a little bit more complicated. I apologize for this being very small and detailed, but it indicates that no longer is it just a matter of lowering your blood sugar. One needs to take into consideration whether there are other comorbidities like atherosclerotic cardiovascular disease, heart disease, chronic kidney disease, or heart failure. One also needs to consider the potential for hypoglycemia, low blood sugar. And then if there is a compelling need to be concerned about weight gain, and then cost. So these are all considerations in how you proceed if metformin and a lifestyle program doesn't reach target goals. So the best approach for older people with diabetes, again, it's more than just about bringing down your blood sugars. There's a balance of risk and benefit. So one needs to consider the neurocognitive function and recheck that yearly in individuals who are older than 65. There's a risk for hypoglycemia. Hypoglycemia is a dangerous adverse effect of many of the treatments. That needs to be taken into consideration. The adjustment for treatment goals, often hemoglobin A1C, blood pressure, and cholesterol are modified for individuals based on the balanced risk-benefit ratio and also quality of life. Then there's the issue of exercise and nutrition. Many elders have a need to have adequate protein intake and exercise in terms of aerobic or resistance exercises. And then, of course, simplifying medication regimens. As you can see with all the different classes of anti-diabetes medications, medication regimens can get pretty complicated. So the overall goal is to simplify it as much as possible without losing any of the benefits. And then finally, costs of medications, as Medicare may cover certain prescriptions but not others. So these are all important considerations. For the elderly with type 1 diabetes, as you recall, 5% of all diabetes cases. If you are insulin requiring diabetic, one needs to consider simplifying the pre-meal medication, and the possibility of actually using an oral medication if it's low dose, combining their insulin regimen with metformin, and then shifting to a morning basal insulin regimen. And this is a picture of an insulin pen, which also makes it somewhat easier to self-administer insulin. So the evidence suggests that despite an abundance of anti-diabetes medicines available in the US, the optimal management for diabetes for the average person still remains a significant and unrelenting disease that has major impacts on quality of life, morbidity, and mortality, as well as healthcare costs. So the influence on other disease risks such as increased heart disease, stroke, sleep deficiency, including apnea in individuals with diabetes, and of course, in more recent times, COVID-19 severity, diabetes also has major implications. So what if diabetes could be prevented or postponed? I'm sure you've heard about the term prediabetes. This is the prediabetes risk test. It's 7 questions related to your risk for being pre-diabetic. And it includes not only your age and sex, but also whether you've had gestational diabetes, if you're a woman, whether it runs in your family, whether you have high blood pressure, if you're physically active, and your weight category, which is this table here, to calculate your risk for pre-diabetes. So you might be asking, what is happening with diabetes in Hawaii and in the Pacific region? And I want to spend a little bit of time kind of bringing it home to Hawaii about diabetes by the numbers. Diabetes and prediabetes is just the tip of the volcano summit. Hawaii sits within the vast Pacific Ocean, as you know. The ocean itself covers 362 million kilometers, of the Earth's surface. So it has its deepest point, which is 11 meters deep, and it's called Mariana Trench. And the tallest mountain on Earth is Mauna Kea. Mauna Kea is 10,203 meters, which is about 33,000 feet. And Mount Everest, which is often referred to as the tallest mountain on Earth, is actually only about 27,000 feet. In addition, the people of Hawaii, the first people of Hawaii, Native Hawaiians, came about 2.5 thousand years ago, estimated. Every Native Hawaiian living today has ancestors who came on a canoe since there was no land bridge to get here. You had to come via the water and come via canoe. And it includes both Oceania and the Polynesian Triangle, which is the genealogical origin of Native Hawaiians and all Pacific Island peoples. So diabetes risk in Oceania, throughout Oceania, is also increased, and that should come as no surprise given our genealogical origin. And of course, here is Mauna Kea. In the state of Hawaii, it, as you well know, is a multi-ethnic state. It is the most racially and ethnically diverse state in the US, and it is a true no-majority racial ethnic state. The prevalence of diabetes by age and ethnicity in Hawaii from 2012, but pretty much the same as it is today, despite the fact that the majority of the population is either Asian, which includes Filipino, Japanese, Chinese, and other Asian populations, and white, and then followed by Native Hawaiian, other Pacific Islander, you can see the prevalence of diabetes. So the current number of cases in Hawaii is actually different according to your age. It's higher as you grow older, and the number of cases also is higher in this green bar, which is Native Hawaiian, and this purple dash line, which is Filipino. So the two highest prevalences are in these two ethnic groups here in Hawaii, the lowest being in white, And then Japanese and Chinese are depicted lower here. The prevalence estimates of diabetes and prediabetes in Native Hawaiian and Pacific Islanders goes back quite a ways. In the 1960s, in 364 individuals, the diagnosis of diabetes was measured as almost 5%. And over the years, it has risen from 5 to 12 to 21 to now almost 30. 30% of Native Hawaiians, Pacific Islanders has a diagnosis of diabetes. And this is data from, I think, 2012 to about 2015. Prediabetes actually was not measured until the 1990s. And at that time, it was measured to be about 15%. And now is over a third of the people that are Native Hawaiian Pacific Islander are at risk for developing diabetes. In addition, I'm showing this as the state of Hawaii's male and female population by age in 2018. And you can see that 65 and older, 17% of the population is in this age group. And that's an increase in the United States of about a third of the population compared to the entire state of Hawaii, which was a 4.4% increase. Hawaii has the privilege of having the longest life expectancy. So if you want to live a long time, come live in Hawaii. It's 81.3 years. And the prevalence of diabetes in anyone in the US over the age of 65 is 25%. So 1/4 of all of our seniors has diabetes. What about type 2 diabetes in youth? These are new cases. And this is a slide from the CDC showing that the highest proportion runs in American Indians, so that's our indigenous Native Americans. Second is Black, non-Hispanic, and then Hispanic. But here's Asian and Pacific Islanders. And while it looks in comparison to these other groups pretty modest, in whites, it's 4%. And here in youth now, these are kids 10 to 19 years of age, threefold higher than in white youth. In terms of adults, this is prevalence, so it's the number of cases currently in 27. Again, American Indian, Alaska Native adults. Black and Hispanics also extremely high. Asians, about half of our American Indian, Alaska Native counterparts. And white. So it looks like whites and Asians in the adult range actually have about the same number of cases. I think the major gap here in Hawaii's population is that we don't really have very good data that's directly from our population. And we often have numbers that aggregate all the racial ethnic groups together, which in a place where there is no one majority racial ethnic group, that can be problematic. And then many of the national studies do not have enough Native Hawaiians and Pacific Island people, the people at highest risk, or Filipinos for that matter. And so Filipinos really ought to be disaggregated from other Asian populations because of their increased burden. So why is prevention the key? Because for most of my professional career, I've spent most of my time caring for patients with diabetes, and now I've sort of shifted to this idea of prevention. Because 1 in 3 adults at risk of developing type 2 diabetes actually lives in the Western Pacific region. And this is shown from the International Diabetes Federation. And you can see that diabetes, as measured in people, adults 20 to 79 years of age, there are many, many people in our location in the world that are at risk for developing diabetes. So I don't want to make it all doom and gloom, because there is some good news in diabetes. First of all, diabetes prevention is making a difference. This is data from the Journal of American Medical Association in 2014, that as early as 2012, we began to see the prevalence of diabetes flattening out and the number of new cases of diabetes actually taking a downward trend. And this was very exciting for those of us who've been in the field for a while. The benefits of the decreased risk for developing diabetes was not actually shared equally by all racial ethnic groups. Let me just kind of go back. And here you can see Blacks and Hispanics here, where the prevalence of diabetes is actually remaining high and going up, whereas in non-Hispanic white is beginning to flatten out and much lower. And here, this is the number of new cases, where you can see in whites, all the decrease in the number of new cases occurring in the white population, whereas Hispanics and Blacks, it's still going up. So the gap between these three racial groups is actually widening in terms of diabetes new cases. In 2018, 4 years later, we're seeing a similar continuation of the downward trend of the number of new cases and the flattening of the number of existing cases. But again, the gap is continuing to widen in some cases for some. And this is data from the British Medical Journal showing Hispanic Black, non-Hispanic Blacks, Hispanics, and this time, for the first time, Asians compared to whites. And you can see a flattening of the prevalence and the number of new cases down here where Blacks and Hispanics are not dropping yet, and I say yet, but in Asians, it's following the same curve as whites. So we are hopeful that we're going to reach a time where the number of new cases will continue to decline. Lifestyle management, however, is critical whether you have diabetes or you're at risk for developing diabetes. And this is a world map showing North America here, and then the Western Pacific, which I showed you the numbers, where there's a 31% increase, but worldwide is a 51% increase. And the increase are actually coming in regions of the world where there's a lot of poverty. So particularly in Africa and Middle East, the number of people who die from diabetes or develop diabetes is astronomically and high, and something that we should think about doing more about. So I want to shift now to think about what's new in prevention research. These are ideas that may be important in the future. They're not in clinical practice yet. And I want to start off again with this idea of preventing diabetes. If we could spend our effort in preventing cases of diabetes, then this conundrum of how to treat diabetes, which is fairly complicated to get optimal treatment, may be either postponed or averted. So this is the main outcome of the Diabetes Prevention Program, which the state of Hawaii was a part of. And basically it shows that lifestyle is stronger than metformin in preventing diabetes. So this is the number of cases per person per year. And the blue are the people that got lifestyle, and the number of cases of diabetes that occurred in this study were lower in people who received lifestyle, were randomized to lifestyle compared to metformin, compared to placebo. And it works in all racial groups. By the way, the Pacific Islanders that were enrolled in this study all came from Hawaii, and they're embedded in the Asian group. So what is meant by a healthy lifestyle to prevent diabetes? The goal of a healthy lifestyle for diabetes prevention is weight loss, modest weight loss of 5 to 10% of your baseline weight, and maintaining that weight loss of 5 to 10% for the foreseeable future. So it's not just a one and then you're done. And our experience tells us that actually keeping the weight off is the real challenge. Here in Hawaii, the healthy lifestyle has been adapted from the DPP program into a program called Piliohana. And it was designed to meet the needs of the population that is at highest risk, Native Hawaiians and other Pacific Islanders. And it was actually trained in the community so that the communities actually did the study and then shared with many different environments, so community health centers, workplace, schools, etc. The Pili program was shared with. And it's at the point now that these new research findings have actually shaped policies. So CMS, the government, actually pays for DPP lifestyle programs. So exercise is great, but it might come as no surprise to many of you that exercise alone is not enough to produce significant weight loss. This is an example of a 200-pound man with 60 minutes of running 4 days a week for several months, showing that if you eat the same amount, caloric intake is unchanged, the individual actually only loses about 5 pounds. And this is with a perfect attendance of exercise and without any resting. So you might ask yourself, why exercise? Well, exercise science is still evolving. There are some mice, not men or human, studies suggesting a crosstalk between muscle and fat, which leads to the beiging of white fat to brown fat. Now, why is brown fat important? So there's a few interesting areas about obesity and diabetes, since obesity is one of the major risk factors for developing diabetes. So healthy lifestyle, as I mentioned, is more than eating less and exercising more. There's this concept of brown and beige fat, which is fat that burns calories by itself. And I think that sounds very attractive. I personally would love to have my fat burned off automatically. All of us have brown fat. It's located in these hot areas on this moving model. It usually occurs around the neck and area and the shoulder area in the back. And then another interesting area is about the microbiome. Perhaps some of the other speakers have talked about it, but the microbiome, our gut microbiome, are companions that have effects potentially on weight and other therapeutic targets. Let's see if I... So brown fat. Brown fat is a type of fat cell that burns energy rather than stores it, like white fat. Brown fat is present at birth, and it regresses over time by adulthood. And it tends to be more abundant in lean individuals versus obese individuals. Beiging of white fat occurs under certain conditions that we know about. One is cold exposure, and one is exercise. So this picture actually shows the location of brown fat in a human, as you can see in the shoulder area, as well as along the neck and in the back. And then with cold exposure, this is thermoneutral conditions, and then you cold expose the individual, and this is all the brown fat that's lighting up. So it can be stimulated. These are thermal images of the neck and upper thorax from 4 normal body weight males of the same family. So it appears to have some generational differences. As you can see, this is before on the left, and after 5 minutes after being cooled, before and after placing one hand in cold water at 20 degrees Celsius. And A and B is a 7-year-old, C and D is a 9-year-old, E and F is a 49-year-old, and G to H is a 70-ish-year-old, all of the same family, healthy males. And you can see with cooling that these areas light up, but there's less of the lit up areas on this thermal imaging as you grow older over time. And studies about brown and beiging of white fat are underway. The microbiome, another active area of research, lives within your gut in a symbiotic relationship. Our gut has an important role in our health and wellness, as well as risk for disease for many things. Besides diabetes and obesity, it also has a role in autism and inflammation. You might have heard about inflammaging, in fact. And certain microbes are associated with leanness, a lean microbiome, if you will, that is also influenced by cold exposure and exercise. So what can I do to work towards a healthy lifestyle? Well, one of the things, and probably too late to start for most of us, which is start early in life. To develop healthful eating and exercise patterns in utero, definitely before 5 years of age. And healthy eating means not only what you eat, but also when to eat. And I think I might have somehow skipped the slides on that, this one, about what time to eat. So this is a really interesting set of studies that have been done in mice about time-restricted eating. So they took obese mice, gave them a high-fat diet, and one group they allowed them to eat whenever they wanted to eat, ad lib, and others they restricted their time to eat to 9 hours a day. Now you might think, well, 9 hours is plenty enough to eat. And it turns out if you time restrict it, these obese mice actually became fit and obese, whereas the obese mice that were given ad lib time to eat, they became even fatter. They became morbidly obese. The real interesting part was if they took lean mice, fed them high sugar, high fat, one, you could get it anytime you want, they became obese, but those who were time restricted actually became lean and fit mice. And this one here, where they gave them a high fat diet in lean mice, they only time restricted them to eat on work days, Monday to Friday. Weekends, they could eat anything they want, when they wanted, and they still ended up being lean and fit. So it suggests that the daily hours of access to high fat and high sugar is important in terms of our fat mass. So I think that's, I'm sorry I somehow skipped that. So the last thing is about exercise. Exercise is a good thing, even if you don't lose much weight. And that's because exercise has benefits on browning or beiging your white fat and the microbiome, and studies are still ongoing, so stay tuned. And research in Hawaii's diverse population is very important to move past the idea of one size fits all. And with that, I will stop and open the discussion for questions. Thank you so much for your attention.